this session on online surgery class. And today is the 17th lecture in the series of OSC. Today's topic is lower GI bleeding. Okay. What is lower GI bleeding? Okay. Last week I had the lecture on upper GI bleeding, and today we are talking about lower GI bleed. Okay, what is the definition of lower GI bleed? Okay, gastrointestinal bleeding is a form of bleeding hemorrhage from the GIT, from the pharynx to the rectum. It can be divided into two categories. Upper GI bleed, which is from the pharynx to the ligament of Treitz, and the lower GI bleed distal to the ligament of Treitz. And what is this ligament of Treitz? You can see here, this is the duodenum, and this is the duodenojejunal flexure. And this duodenojejunal flexure, or DJ flexure, is suspended and plastered onto the posterior abdominal wall by a ligament known as the ligament of Treitz. It attaches it to the orifice of the esophagus into the abdomen. So all the bleeding that comes distal to this, that is the jejunum, ileum, large bowel, right side bowel, left side bowel, and rectum, they're all considered lower GI bleed. Normally, there is the normal fecal content of the stool is 1.2 mils per day. Okay, if the loss is more than 10 mils per day, then it is significant and needs to be investigated. Okay, the important term to remember here, in upper GI we talked about hematemesis, but in lower GI it's called hematochezia, passing of fresh red blood in the rectum, through the rectum. Hematochezia is the process of passing bright red blood in the stools. It can be arterial, which is bright red in color, as can be seen here, or venous is dark colored. And the other important thing is occasionally you also get a patient with melena. Although melena is black stools, is a sign of upper GI bleed, but occasionally it can be due to bleeding in the lower GI tract, especially in the small intestine and the cecum. Okay, what are the causes of lower GI bleed? Okay, this chart here shows you the various causes. 95% of the causes are from the colon. Okay, colonic bleeding accounts for 95%, and bleeding from the small intestine only accounts for 5%. And in the colon, the common conditions are diverticular disease of the colon, hemorrhoids or anorectal diseases such as hemorrhoid, which is the most common cause of bleeding, neoplasia, carcinoma of the rectum and colon, and angiodysplasia. Okay, these are the common causes of bleeding from the lower GI bleeding. In the small intestine, usually is due to angiodysplasia and Meckel's diverticulum, which is important, especially in children, and mesenteric ischemia in patients who are adults, older patients. Okay, this picture here shows you the various sites of bleeding: angiodysplasia on the right side, diverticular and cecum, carcinoma of the cecum. On the left colon will be your ischemic colitis, polyps, carcinoma of the colon, and hemorrhoids. Okay, hemorrhoid is one of the most common causes of lower GI bleed. Okay, now we come to the causes by age groups. Adolescent and young adults, Meckel's diverticulum should be considered. Others will be inflammatory bowel disease and polyps, but small bowel or large bowel polyps. And adults to 60 years of age, most common cause is colonic diverticular disease, neoplasms, carcinoma of the colon, and hemorrhoids. And adults over 60, you have to think of AV malformation, such as angiodysplasias, diverticular disease of the colon, and neoplasms, carcinoma of the colon. Okay, these are the common causes of lower GI bleed. A summary: diverticulosis, angiodysplasia, colorectal cancer, colitis, and due to inflammation, radiation, or ischemia, and anorectal abscess causes, especially hemorrhoids. Okay, this summarizes the three most common causes: hemorrhoids, diverticulosis, and AV malformation or angiodysplasias. Now, what are the symptoms of patient with lower GI bleeding? Bleeding in the stools. You must describe in the detailed history of the patient. You must be able to determine these three things, three factors of hematochezia. Is the bleeding initial, that is before defecation? And these are usually due to external causes such as anal fissures, traumas, and fistulas or abscesses. Terminal hematochezia, that is bleeding after defecation, and the classical and the most important one is hemorrhoids. And the last one, which is most common, is the stools which are totally mixed with blood, and these are usually due to causes higher up in the colon and intestine, and these are usually due to tumors, vascular dysplasias, angiodysplasias, polyps, and other forms of inflammation. Then you have to look for the associated symptoms in this patient. Pain is an important associated symptom, okay, and the pain is usually colicky and is due to infection or some lesions over the skin. Discharge of mucus together with the blood suggests it is an inflammatory cause, such as inflammatory bowel disease, infection, colitis, or tumors. And abdominal symptoms, usually cramping pain. These patients may have lower abdominal pain bilaterally. And you must also not forget the symptoms related to the primary cause. For example, if it is colon cancer, the patient may have other symptoms like loss of weight, loss of appetite, lethargy, constitutional symptoms, and also change of bowel habits. And lastly, you must also look at the color and amount of the blood that the patient has been passing. So the important points in the history: hemorrhoids, bleeding after defecation, usually fresh blood drops on stools, sometimes spurting of blood after defecation, sometimes associated with a prolapsing lump coming out of the anus due to prolapse hemorrhoids, and perianal discomfort. Anal fissure is the fissure in the anal external fissure in the perianal region, and these are usually present as fresh blood streaks on stools, and is usually associated with pain, very sharp pain, which lasts hours after the after defecation. Inflammatory bowel disease, okay, usually blood and mucus diarrhea, usually painless unless fistulas or fissures coexist, and they also have systemic complication symptoms like low-grade fever. And anyway, inflammatory bowel disease is not so common in our country. And of course, the last and the most important you mustn't forget is carcinoma of the colon, which is one of the most common malignancies in our patients. And this is usually either colon or rectum or colorectal carcinomas. And the bleeding is usually painless, associated with loss of weight and change of bowel habits. What are the physical signs that can be seen in this patient? There are a number of three categories. The first one is external causes of bleeding. That means lesions in the external area, the anorectal region. And these include the following conditions: perianal conditions such as anal varix, thrombosed veins, fissures, and most important, prolapse piles. The second category is related to blood loss. Signs related to patients present with signs related to the blood loss, and these include pallor, hypovolemia, okay, abdominal distension, tenderness, and in the abdomen, and rectal examination may show fresh bloods, and there may be a palpable mass in the rectum if it is malignancy. And the third group is related to the primary cause, which I mentioned just now. Okay, this includes abdominal mass in the case of an inflammatory mass or a malignant or tumors, tenderness and guarding like in diverticulitis, and then systemic constitutional symptoms like lethargy, loss of weight, and emaciation. These are all important signs that you must look for in these patients. Now, having gone through the history and physical examination, how will you clinically assess the patient's bleeding, the severity of the bleeding? Okay, first you take a history, good history, amount of bleeding, symptoms, frequency of bleeding, and then also the uh, evidence or symptoms of blood loss, tiredness, giddiness, breathlessness. These are important things that you must look for in these patients. Second, on examination, look for the mental status, pallor and lethargy, breathlessness, pallor and cyanosis. These are important signs that you must look for in these patients with passing blood in the stools. And then the vital signs are equally important. Pulse rate, which is one of the earliest signs. Tachycardia is one of the earliest signs of blood loss. Blood pressure, hypotension, cold and clammy extremities. And then others, things that you can use will be hemoglobin level, renal and liver function tests, AB, arterial blood gases, and chest X-ray. Very important to also go into the pre-morbid conditions the patient may be having, especially elderly patients on various types of medicine, such as medications that can cause bleeding problems, such as antiplatelets, and drugs, okay, such as antiplatelets. These all can cause patients' pre-morbid conditions which affect the outcome or prognosis of the patient with PR bleeding. And of course, you can use the Blashford and Rockall score, which were primarily used in upper GI bleed, but sometimes it can be modified to help you to as a guide to assess the severity of bleeding. Okay, so the assessment includes general condition, pallor, severity of or degree of pallor, pre-morbid conditions, and age. These are all important conditions that you must be able to assess the patient. Then you got your vital signs, heart rate, blood pressure, pulse volume, and saturation, partial oxygen saturation. And the Blashford-Rockall scoring system may be used to assist in your assessment. Once you have assessed the patient's severity, you should be able to classify him into mild bleeding, moderate bleeding, or severe bleeding. And the other important factor that must be must be assessed is whether the bleeding has stopped, which most of the time the bleeding stops when they come to the hospital. And the other one is whether the patient continuing to bleed. If he is continuing to bleed, then it becomes a real emergency. Okay, these are the Blashford score on the right here, which need for intervention, and your Rockall score. These are the parameters that you have to assess, which I have gone through in detail in the last lecture. Okay, now coming to what are the investigations that must be done for these patients. Okay, routine investigations include this: chest X-ray, renal function, liver function, ECG, full blood count, especially is your full blood picture, especially your hematocrit, PCV, and hemoglobin levels. Specific investigations, most important investigations is endoscopy, and in this case is colonoscopy. And sometimes you may have to do a OGDS as well, because if you're not sure whether the bleeding is from higher up. Okay, so these are the things. Endoscopy in the form of colonoscopy remains the single most important investigation for patients with lower GI bleed. Other investigations include mesenteric angiogram, which can be a CT angiogram, which is nowadays is more commonly CT angiogram is done, and the traditional catheter, direct catheter angiogram. These are the two types of angiograms can be done. For angiogram to be positive, the bleed must be more than 0.5 mils per minute. If the bleeding rate is slower than this, then these angiograms may not detect the bleeding. Then the other one is the RBC TEC scan, okay, 99 technetium scans, where the RBC are tagged with technetium, and the RBC scan is done over the abdomen to see where the site of extravasation of the RBC from the mesenteric vessels. And for this to be positive, the bleeding must be at least 0.1 mils per minute. So this is more sensitive compared to angiogram. Even at 0.1 mils per minute you can detect, whereas angiogram needs 0.5 mils per minute to blood loss to detect the flow. The other another investigation is your video capsule endoscope, where a patient is swallows video capsule containing microscope, video cameras, and all that, and this can be used to uh, send pictures of the various part. It travels through the GI tract. Okay, so as I said again, to reminder, colonoscopy is the most important investigation, and it is not only diagnostic and can be therapeutic as well. Okay, these are pictures showing you how colonoscopy is done. Here, there's a screen here, and a colonoscope is passed into the anus and rectum and guided upwards into right until the ileocecal junction. Okay, patient lies in the lateral position, fully flexed, sedated, and patient is as you do the process, patient is monitored. And this is the colonoscope. Okay, the channels that are there similar to the gastroscopy. Okay, this is a picture of a modern day flexible colonoscope. Okay, it is a four-way tip deflection, 4 directions, and it is typically 160 to 170 centimeters long, and it is about 12.8 millimeters in diameter. Okay, it has got four main channels: working port and suction, camera, light uh, light sources, and irrigation in insufflation, which is very important to uh, give proper visualization of the lumen of the colon. Okay. This slide shows you the normal colonoscopy findings in the various parts of the lower GI tract. Here you have the anal canal, rectum, transverse colon, sigmoid colon, descending colon, and ascending colon. Okay, these are all normal pictures of the various parts of the large intestine. And here are some pathological changes that can take place. This is a tumor here, carcinoma of the colon, sigmoid colon. Here is carcinoma of the rectum. Okay, very polypoid lesion here. These are usually biopsied and confirm the diagnosis. And these two pictures show you pockets, openings in the uh, sigmoid colon. Okay, and these are the openings of the diverticulum. Okay, so these are pictures of colonic diverticulum. This is a picture of ulcerative colitis of the sigmoid and rectosigmoid area here. This is superficial ulceration and hemorrhagic pores. So this is a typical feature of ulcerative colitis, and this is a colonic polyp. And this picture shows you actively bleeding diverticulum. See the fresh blood oozing out from the openings of the diverticulum. Fresh blood here. And here is a recently, there's a blood diverticulum possibly here. There's some clots there, so this is, the bleeding has stopped. Okay, this is angiodysplasia of the ascending colon. It's a close-up view. It's a form of congenital AV malformation and leading to bleeding, trauma, and bleeding. And here is a picture of a colonic carcinoma ulcerative colon of the cancer of the colon with inflammation of the and involvement of the surrounding areas. And this is a colon polyp, okay, bleeding, actively bleeding. Next, we come to mesenteric angiography. So mesenteric angiogram, the superior and inferior mesenteric arteries are cannulated and dye injected. In this case here, dye is injected, and then you watch out for the flow of the blood. See whether there's any leakage of blood from the branches of these arteries. Okay, so in this procedure, the bleeding rate should be about not less than 0.5 mils per minute for the extravasation to be detected by angiography. Selective angiography is done, as I said, catheterizing the arteries, the SMA, superior mesenteric artery, and the IMA, inferior mesenteric artery. And this is cannulated using fluoroscopic guidance. Okay, and this procedure not only can use to detect the leakage of blood in a certain location, it can also be used to seal these blockages or stop this bleeding by embolization of the bleeders. So therefore, this angiography is not only diagnostic, it can be used for therapeutic purposes as well by embolization of the bleeding vessels. So here in this picture, the inferior mesenteric artery is cannulated and dye injected. You see the various branches here, and here in the left ilia fossa, there is collection of blood, abnormal extravasation. So most probably the bleeding is from the sigmoid colon. Okay, now this is advances in angiography has made it the visibility much better, okay, by subtracting the unnecessary details. So this is called subtracted SMA arteriogram, where the SMA is cannulated, dye injected, and then you see a extravasation of the dye in the right ilia fossa, okay, in the ileocolic artery here. Okay, so that side, so the bleeding must be in the cecum or ascending colon. And this is a CT scan, okay, CT angiogram showing you the diverticular hemorrhage on the arterial phase. This is the arterial phase here. There's extravasation of blood in the left iliac fossa here. And here, and the blood is uh, detected in the within the lumen of the sigmoid colon. Here, CT angiogram showing you collection of blood, extravasation into the right side ascending colon. And these are pictures to show you the tagged RBC scan. Pictures of tagged RBC scan. Okay, the RBC taken from the patient is then tagged with a radioactive isotopes such as technetium, and then re-injected back into the patient, and radioisotope scanning is done of the abdomen. Okay, here you see, you follow the path of the tagged RBC, the path and the behavior of these tagged RBCs. So this is a normal normal scan, aorta, iliac, and femoral veins here. Okay, you can see this; they're all within the walls of the arteries. In this case here, there's extra vessation of this extra collection of this tagged RBC in the right ilia fossa. So there's probably a focus of bleeding in the right side of the abdomen. So most probably it must be the ileocolic vessels which I showed you just now. So the bleeding must be in the cecum or ascending colon. Okay, next we come to this video endoscope, video capsule endoscopy, VCE. So in this, we use a high-tech capsule which the patient swallows. The capsule consists of a light source, the camera, very high-powered camera, LED lines, microchips to analyze and and transmit the photos to the computer, and then it's got microchips and battery powered. Okay, so this capsule is after overnight fasting, it is patient swallows, and then we scan the whole abdomen from the esophagus right until the rectum, and to pick up these radio signals from this capsule that you swallowed. And so as the capsule travels down the GI tract, it transmits pictures and videos uh, to through the chips and through the antenna that is available, and then this is then recorded and in the computer and analyzed. Okay, so this is a close-up view of a capsule with all the gadgets within it, and these are some of the companies that produce these, manufacture these capsules. Okay, this X-ray shows you the capsule in the left ilia fossa. After it has traveled all the way down through the intestine, small and large intestine, to reach the right ilia fossa. As it does this travel down, it transmits numerous pictures and videos of the bowel as it travels along. These are some of the pictures showing you normal bowel, small intestine and large intestine. Okay, next we come to the management of lower gastrointestinal bleeding. First, the first treatment is resuscitation and general management of the patient. You must understand the patient is bleeding and he needs to be stabilized. Okay, you have to assess the severity of the bleeding and resuscitate the patient. The resuscitation consists of replacement of IV fluids, which consists of crystalloids such as saline and Hartmann's procedure, or colloids such as Hemacell. Blood transfusion if necessary, if the patient has been bleeding profusely, and others that can be replaced is would be your Hemacell and Dextran, which can temporarily, while waiting for the blood, these can be transfused to improve the volume. Patient may have to be given nasal oxygen. Insertion of a nasogastric tube is usually necessary, and monitor the urine output with the use of a urinary catheter. Patient has to be monitored at least in the HDU, high dependency unit, or ICU. Close monitoring of the BP, pulse, and saturation. Patient may have to be inserted with a CVP monitoring, and patient has to be given vasopressin infusion, as well as proton pump inhibitors injection. Okay, this is two pictures here. It shows here the patient is being transfused blood transfusion, and here there are various types of plasma expanders that can be used for these patients. Hemacell and Flamacell, these are some of the common ones. We come to the specific treatment for these patients. As there are three forms: endoscopy, angiogram, and surgery. Endoscopic treatment consists of ligation of the bleeders, clipping of the bleeders, cautery, injection of the bleeder. So all these endoscopically, the bleeders can be arrested by the various methods here. Then you can use angiogram. Usually a catheter angiogram may be used, and this can use to not only to localize the bleeding by injecting a dye and looking for site of extravasation of the blood, but at the same time, you can also embolize the bleeder. Once you embolize the bleeder using gel or some form of foams, then you can stop the bleeding as well. And lastly is surgery. Surgery can be either laparotomy or laparoscopy, and the procedure involves segmental resection of the bleeding segment or the intestine, such as hemicolectomy,
or even total colectomy in cases where you are unable to localize the bleeder and the patient is very serious. The other important procedure that is done is Hartmann's procedure with colostomy. It is usually a temporary colostomy. Okay, these are some of the procedures. You see the diverticulum bleeding. So a clipping of the bleeding diverticulum. Okay, where a clip is applied to the base, as shown in this diagram here. This is the diverticulum. There's a bleeder here, and this bleeder has to be clipped on either side of the leak. So this is a patent artery. You place a clip here and clip here, and this will control the bleeding from the diverticulum bleeding. Here, injection of adrenaline or tranexamic acid is to stop the bleeding. Okay. Then this is angiodysplasia, and the best treatment is using diathermy probe, cauterization. See here, see there's a bleed, this bleeding here, and then you stop the bleeding. And this is polypectomy. In case if polyp is the cause of the bleeding, then you can do a polypectomy, which involves snaring of the polyp and then followed by cauterization of the base. Okay, here, first snare the polyp with the loop here through the endoscope. Snare close tightly, and here the polyp removed. And once the polyp is removed, the base is cauterized to stop further bleeding. So it's snaring and cautery of the colonic polyp. Now, what are the surgical procedures that can be done for patients with lower GI bleed? Okay, the surgical things can be segmental resection of a small bowel. If it is bleeding from the small bowel, is the lesser problem. With bleeding from the large bowel, it is more difficult. Some form of colectomy, such as hemicolectomy, or even total colectomy may be the answer. And of course, Hartmann's procedure, which is usually done as an emergency procedure. Hartmann's procedure involves proctosigmoidectomy with a temporary colostomy. As shown in this diagram here, Hartmann's procedure, there are 4 steps. First one is resection of the rectosigmoid colon. See, the rectosigmoid colon is removed. This is step A. Step A, where this segment of the colon with the mesentery, okay, is removed. So the bleeding segment of the colon is removed. Then second part is B, the anorectal stump, closure of the anorectal stump. Okay, so this is a pattern here. So you close up the stump and you leave it in situ, leave it intact. The third part of C is your colostomy. And colostomy, the descending colon is brought out in the left iliac fossa as an end colostomy, which is normally a temporary colostomy, which can be removed and re-anastomosed a couple of weeks later. And the last one is the third process D is closure of the colostomy and re-anastomosis, a colorectal anastomosis. This can usually done when the patient is more stable, usually a couple of weeks later.
Okay, finally we come to the summary, the management of lower gastrointestinal bleeding. Okay, this is done in 4 stages: assessment, scope, other investigations, and surgery, either endoscopic method or open surgery. Okay, first, under the assessment, first you assess the patient by clinical assessment as well as by proctoscopy into mild bleeding, and when the bleeding has stopped, moderate bleeding, and severe bleeding. Now, in the case of patients with mild bleeding, which form the large majority of patients, when the bleeding has stopped, you can prepare the patient for bowel preparation and colonoscopy as soon as possible. At the colonoscopy, you may find some positive findings, which can then be treated by using endoscopic procedures. And if necessary, the patient is subjected to surgery. With moderate bleeding, when do the colonoscopy, if you do not find any positive findings for the bleeding, If it is negative, then you may have to proceed with a tagged RBC scan. And if the bleeding is not severe, patient is stable, you may even prepare the patient for a video capsule endoscopy. And if there is any positive findings, you subject the patient to surgery. Now, in the case of severe life-threatening bleeding, which is a very important group of patients, although the number may be small, you have to subject the patient to some mesenteric angiogram. The patients are usually not fit for colonoscopy, so you go for a mesenteric angiogram, and the easiest will be a CT angiogram. If this which is available more widely, rather than the uh, catheter angiogram, which has to be done if necessary. If there's positive bleeding, then you can continue treatment with vasopressin or angiographic embolism through the angiogram. If it is negative, you do not detect any source of bleeding, then you may have to do an urgent or emergency intraoperative colonoscopy under general anesthesia with preparations for laparotomy, exploratory laparotomy, and surgery. And in these patients, most of the time they can be uh, dealt with segmental resection of the colon to stop the bleeding. Or if you are unable to find the source, then we have to do a total colectomy.
Okay, finally, the summary of today's lecture. Okay, what is your take-home message from this lecture? First, you got these are the causes of LGIB, lower gastrointestinal bleeding. We have studied clinical presentation, classify according to mild, moderate, and severe. Investigations, special investigations for this particular condition is most important is colonoscopy. Others include angiogram, which can be catheter angiogram or CT angiogram, RBC text scan, and examination under anesthesia if the patient has got no time to go through all these investigations. Okay, on the table, colonoscopy and EUA. And the management is generally general and specific. General management is resuscitation. Specific management is either surgery, endoscopy, or angiography. And you go back, you have to read up on, for further information, you must read up on colonic diverticular and complications, angiodysplasia, CA colon, and another condition known as massive lower gastrointestinal bleeding. And this is usually due to diverticular or angioplasia. Okay, angioplasia. Colonoscopy is the mainstay of treatment or investigation. What are the indications, preparations, procedure, and aftercare? Thank you for joining me for this session.